Welcome to the EAU podcast series on Andrology Chronicles, Messages for Men's Health. Join us as we delve into insightful discussions led by Dr. Rees, a consultant urological surgeon and andrologist, alongside Dr. Sahdev, a consultant urologist and andrologist both at University of Southampton in the United Kingdom. In this fourth and last episode, Dr. Rees and Dr. Sahdev will navigate priapism and approaches for both ischemic and non-ischemic cases. Join us as we embark on this informative journey.
Welcome to the fourth episode of the Andrology series. Today we're going to be discussing priapism and tailored approaches to both ischemic and non-ischemic cases. I'm Sahdev, an andrology consultant from Southampton. I'm here with my colleague Rees, who's a fellow andrologist, and we're going to be talking first of all about a patient. So if I could ask you about the patient that presents, say, within 24 hours with a priapism, what's the best way to approach this case, would you say?
Okay, well, hi, Varun. Yeah, it's not an uncommon andrology emergency, is it? And often dealt with by the juniors, by the registrars, the residents. So it's important to get this right because it's basically an emergency. I mean, that's the first thing to say. Yeah. You get called about a priapism. You've got to wake up, you've got to focus and decide. The key thing is this an ischemic episode or not? We used to call it low flow, but essentially, is this ischemia of the penis, which could lead to necrosis of the penis, so very bad, or is it a non-ischemic high flow situation? So that's the first thing that goes through your head. The second thing that goes through my head is how long has this been going on for? Because that also determines what sort of damage has been done to the penis. And you've told me this is a 24-hour case, so I'm going to go and get up. I'm going to go and see the patient straight away. I mean, it's the equivalent of a testicular torsion, isn't it, where there's potentially critical tissue under threat. So go and assess them. You examine them, confirm it's a priapism, obviously do an abdominal examination, rectal, penile, neurological as well, then some basic blood tests, including a full blood count to make sure there's no issues with sickle cell or leukemia, etc. And then we need to quickly focus on whether this is an ischemic or non-ischemic priapism. And the ways to do that is either with a corporal blood gas to see if the blood is oxygenated or not, or a penile Doppler, which will show you whether it's high flow or low flow, or, of course, both in an ideal scenario. But you definitely need one or two of those. And the easiest thing often is to just get the blood gas done. And very often you get your answer. So that's the initial assessment. And then let's take the commonest situation by far is an ischemic priapism. Lots of different causes. But if you catch this in the first 24, 48 hours, then you need to try and treat it in order to get rid of it, in order to get the erection down. And first thing is obviously to aspirate. You do a penile block, and then you'd pass a syringe into the corpus cavernosum and try and aspirate blood. And often you get in ischemic priapism dark blue ischemic looking blood. And once you've managed to dislodge that type of blood, then you should start to see brighter red oxygenated blood coming in. And then you know that the muscle is getting a bit of oxygen again. And that's what it needs in order to contract, in order to detumesce. So that's essentially the objective there.
Absolutely.
And that's your first step.
So it's a compartment syndrome of the penis, essentially, isn't it?
Absolutely.
Yeah.
You need to get blood flowing back in there.
Yeah.
And aspiration is the first step.
Okay, so say if that first step is not effective, so there's ongoing priapism, what would you
Well, sadly, very often, you might get some response, but it's not common or often that aspiration alone does the job. But if you can get some, as I say, some bright red blood, some oxygen in there, that allows the muscle to contract, then the next step really would be phenylephrine. Phenylephrine is an alpha agonist agent. So it stimulates the adrenoreceptors in the muscle and generates contraction of the smooth muscle. And that needs to be injected in 200 microgram aliquots, not 200 milligram, but 200 micrograms. So quite a small amount into the corpora, and ideally under a cardiovascular monitoring to check for any systemic absorption. But you can do that repeatedly up to 1,000 micrograms. And it's not uncommon, certainly in the early stages, for priapism depends on the cause, but if the cause is reversible, for instance, if they've had an intracavernosal injection for their erectile dysfunction and you inject phenylephrine, that's often very effective in that situation. But yeah, after aspiration, it's phenylephrine injection.
So say you've done your phenylephrine injection, you've gone up to the maximal dose.
Yeah.
They've still got a residual priapism. It's not resolving.
Yeah. Well, in which case you then need to move from the emergency department to the operating theatre. And most, if not all, urologists should be able to deal with this because it's an emergency. It's not something you can just sit back, go back to bed, or hand it over to another hospital. You need to get on and do a shunt. And the teaching these days is to do a distal shunt, often called a winter shunt. And this is where you create a communication between the glands, which is the corpus spongiosum, which is low pressure. You create a communication between that space and the cavernosal space, which is the area where we have our high pressure and our compartment syndrome. And to do that, you have to make a little incision in the gland skin, lateral to the urethra, dorsally, and then pass either a true cut needle or a 11 blade, and you have to pass it right through into the corporal tips. And you can feel the corporal tips because the erection is solid. You put your fingers on the gland, you'll be able to feel the corporal tips, and the blade or the instrument certainly needs to go in to the corpora, and you need to do that on both sides. And once you do that, you will normally get quite a rush of, again, dark blue deoxygenated blood coming out of the incision. And then that's your opportunity to decompress the corpus cavernosum and take the pressure out of it and hopefully reverse the situation. And the key thing here is to stay lateral and don't point any sharp instruments at the urethra, because you do not want to create a urethral injury. And again, it's a relatively simple, quick procedure that should be done for anybody who's failed the initial maneuvers.
And you feel that every andrologist, or every urologist rather, should be able to carry that out?
Absolutely, because if a patient comes into any hospital in the country, there's no time to waste. So the attending urologist, general urologists, whatever, needs to be able to do this as part of their basic urology, just like we can incise and drain abscesses or put a suprapubic catheter in. We should be able to perform this distal shunt. It's relatively straightforward, and hopefully during training at some point you'll come across this.
So say you've done your T-shunt and you're still not really happy that things are improving. Are there any kind of adjunctive things you would consider at this stage? And also, who would be doing this procedure normally? So say you've got to that stage.
Yeah. Well, that's it. And I mean, if that distal shunt hasn't worked, you've then, I think, really need to engage andrology. That may be in a different hospital or maybe within your unit, but essentially, it's getting a little bit more problematic, isn't it? But again, if you're in that first 24 hours, there is a chance, and certainly there was a fellow of ours in London, Evangelos Sakarakis, who wrote the paper in 2014, in fact, who showed that if you performed a T-shunt in the first 24 hours, that the resolution rate was really high. It was really good. So it's definitely worth doing. And I think, it was a good 80-90% of priapisms, ischemic priapisms, would be resolved if you managed to perform a distal shunt within the first 24 hours. The problem is that the minute it goes beyond that, 48 hours, you're looking at a much lower success rate of about 40%. And then on and downwards it goes, because by then the muscle has died, and whatever you do to it, it will not contract anymore. But yeah, I mean, I think that was, proof that if you get in early, you can actually potentially salvage the situation.
So you then carry out an extra maneuver, the snake maneuver.
Well, yeah, I mean, the additional maneuver here really is to pass a dilator down into the corpora itself. Now, this is obviously a little bit more specialized, not quite in the territory of non-penile surgeons, but there have been the tunneling or the snake maneuver has been described, where once you've done your distal winter shunt and you've created a an opening in the tip of the corpora, you then pass a dilator down into the corpora, and that helps to expunge clot and blood out of there and adds something to the procedure. But, I think this is something that probably ought to be done by andrologists. Yeah. So if they're available, it's an adjunctive maneuver, essentially.
Mm-hmm. Okay, so moving on to someone that presents later.
Yeah.
These can be a bit more difficult to work up sometimes.
Yeah, indeed.
So how would you approach someone that was in the sort of 2 to 3 day post-priapism category?
Well, this is a bit more tricky because if they come straight away, it's easy. We just do what we've just described. If they come a week later, well, the game, we've lost the game. We need to talk about implants or whatever. This zone in the middle, day 2, day 3, we're not quite sure what's going on, really. How reliable is the history? How much of the muscle is deoxygenated? Is it partially ischemic, etc.? So you've got to always give them the benefit of the doubt. So in that 48-hour, 72-hour period, I think it's still worth just going through the motions of aspirating, phenylephrine, distal shunt. You're giving them the benefit of the doubt, but there's no doubt that in this time frame, that the success rate, as I said earlier on, is going to be lower.
Yes,
and therefore, the chances are you will try those things, and I think it's perfectly reasonable to do that, and you might be lucky. But actually, if we go back to the paper I was referring to earlier on, we're talking about a 20-30% success rate. So it's gone down, but it's not nil. And if it fails, then you've definitely got to. If your distal shunt fails, you need to refer to the andrology services. And we used to talk about proximal shunts as the next step, but they really have gone out of fashion. There's no evidence that they really were. I've never seen a proximal shunt be effective. And therefore, more recently, there's been a vogue for something called penoscrotal decompression. So if the penis is still very rigid at 3-4 days, your distal shunt hasn't worked, then you could potentially, I say andrologists, people familiar with penoscrotal surgery would potentially incise, very similar to a penile implant incision, actually.
Yeah.
Penoscrotal junction, corporotomy, dilators up and down the corpora, and then again getting better removal of the clot, essentially, and more success in getting the erection to come down, reducing the pressure in the penis, and increasing the likelihood that fresh oxygenated blood can flow in.
Could you see a time where that would be the primary approach, or?
Yeah, well, we're in an evidence-free zone here, aren't we? And that's all I can say is that experienced people are, in both sides of the Atlantic, are talking about this procedure as a better option than a proximal shunt, and I think, I believe it is personally, because I've done it myself.
Yes,
and I've managed to D2MS priapisms, fairly consistently with his method. So I think there is a place for it.
Yeah.
In
so
that
the initial evidence
interim period
looks good, but we're not quite there in terms of being able to advocate this as
There's not many publications on it.
No. Okay, so coming on to our third category of patients, those that have presented after 3 days down the line from the onset of their symptoms. What are the main differences in terms of your approach with this group of patients? Yeah,
so if you've got a reliable history that this priapism has been there for days on end, we know that ischemia, in fact necrosis, has now taken hold in the penile muscle. And the chances of these guys recovering is almost nil, isn't it? Because they've still got an erection. The pain eventually goes away because the muscle dies. So if you're presented with a patient, 5 days, 7 days priapism, ischemic priapism, then you're going to have a serious chat with these patients about the prognosis. The prognosis is very poor, and there's not a lot of purpose really in doing shunts on these men because you've missed the boat. And therefore, the emphasis come round to prognosis and future aspirations. Do they wish to preserve erectile function or not? I mean, if they don't, then it's relatively easy. You just give them analgesia and wait for the penis to fibrose, but then it will remain like pretty woody and useless for the rest of time. But the majority of men presenting with priapism are sexually active and aspire to restoring sexual function. And therefore, the next step really for us then is to talk about penile prosthesis. It's the only way really of truly salvaging function in this group of people.
Okay, and when it comes to the timing of this, following the initial maneuvers, say, for example, in a patient that's had a T-shunt, how long would you wait before offering them an implant and giving them a date for surgery?
So there are a few things here, aren't there? You've got the patients who've been through initial management that have failed.
Yes.
And you've got the men who presented really late.
Yes.
And these men are all potentially eligible or best treated with a penile prosthesis. Now, I think, in fact, myself with colleagues at UCLH, David Ralph's group, back in 2002, one of the first papers on this, the management of low-flow priapism with immediate insertion of penile prosthesis back in 2002. This basically described going in early with a prosthesis, and the rationale for that is that once your penile muscle is effectively necrosed, it then becomes fibrotic. And if you wait a few months or put them on a routine waiting list for surgery, by the time you get to doing their implant, the fibrosis is so dense and so severe that A, it's a very difficult operation, and B, that will translate to a far higher complication rate, higher infection rate, higher risk of perforating or doing damage because you're fighting fibrotic tissue. And finally, you cannot get a good space or a decent size implant in there. So the time to do it is before the fibrosis has settled in. But there is also the issue of avoiding infection and putting an implant in so soon that the shunts and the aspirations and everything that's been going on may increase your risk of infection. And therefore, you kind of want to wait certainly a few weeks for that swelling and everything to go down before going in. So what is the answer? Well, I suppose the optimum is 3 or 4 weeks, I would say. And in particular, to answer your question, if you've had a shunt, distal shunt, you've really got to make sure that when you're dilating and inserting your implant, that you don't reopen that shunt. And you could, one of the things you could do is just put your finger and thumb and clamp across the glands whilst dilating.
Yes.
Or it may be putting a sort of shorter implant on the shunt side if necessary, or fixing the implant. But it is important to try and avoid a distal perforation. And there's no doubt that in this context, in this setting, that surgery is more challenging and complication rate is higher than it is in straightforward implant surgery.
Okay, thank you, Roland. That was a very good summary about managing low flow or ischemic priapism. We'll just move on now briefly to discussing high flow priapism. How would you generally approach these patients? How would you does the usual patient present?
Well, yeah, this is the good thing about high flow priapism is it's not an emergency. So you've obviously got to make the diagnosis. So you need either good flows on Doppler or well oxygenated blood on corporal blood gases. It often follows trauma, so an AV fistula as a secondary to trauma. It's often painless, well, it's always painless, and sometimes it resolves itself. So conservative management is an option, but if it's not going down, then certainly some imaging is required. And so angiography would be the next step after your Doppler. And the angiogram then may show a cavitous fistula, in which case it's then over to interventional radiology, really. It's not really a job for urologists. And certainly in Southampton, we've shown some nice super selective embolization procedures with gel foam, which can embolize the vessel. The priapism goes down, and in fact, in our experience, the majority of these patients also regain normal erectile function, although you've got to warn them that obviously embolization could potentially harm or damage their erectile function in the future. But yeah, so essentially it's interventional radiology's turn to step in.
Yes. Okay, thank you very much. So we've covered key aspects in the management of ischemic and non-ischemic priapism, and we've discussed patients presenting at various stages after the onset of their disease. Thank you very much.
Lovely, thank you.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.